Hey guys, welcome to the podcast. Today we're going to go over, does spinal decompression actually work? My name is Dr. Cassidy Boelk. I am a doctor of chiropractic and a certified spinal decompression doctor here in San Diego. And for the past 21, almost 22 years now, I've been helping people in my private practice, mainly local San Diego people here, but we help a lot of people that fly in and drive in from out of town and out of state as well. And mainly we talk about and help people with neck pain, sciatica, degenerative disc disease, disc bulges, herniations, these type of conditions in their lower back and their neck, radiating arm pain. And really, for a lot of these people, they're not able to do all the things that they want to do. And I can relate to that. I broke my back when I was 16, and I've had multiple disc issues from all the sports and surfing and snowboarding and stuff I've done. And my goal is just really simply to allow people to understand what options do they have rather than getting stuck in this waiting period for 3 weeks, or having to go through physical therapy for 4 weeks or 6 visits or whatever it is before they get some actual help. So hopefully this podcast will give you some clarity, and we'll go over a little bit more about how decompression works. So we're going to go through some key points and on how it works. And one of the questions I always get, or not always, but a lot of people ask me, hey, does the decompression, does that really work? Well, obviously there's many factors. It's not a one size fits all. It's not 100% success rate like anything in life. It's kind of like someone saying, hey, does working out really work? Well, if that person's not sleeping and resting and they're not having proper nutrition and protocols, then it probably doesn't work. But for the person that does all those things, yes, it probably does work. So it's a very generalized question, but let's try to narrow down just a little bit. So really, the first section we're going to go over is, what are we trying to do with spinal decompression? So one of the biggest issues with discs is discs. We look at it here. This is the bone, and then in between's the disc, and there's the bone, and then this little yellow guy's the nerve. Well, fortunately or unfortunately, discs are avascular tissues, and that simply means there's no direct blood supply, right? You cut a finger, it's gonna bleed, heal, no big deal. The discs, unfortunately, don't work that way. Discs require motion, so all day long, those discs gotta be moving, right? You sit, stand, bend, twist, turn, the disc compresses a little bit, and then it opens. This is called spinal imbibition. It's like a little pump system. And that pump basically allows the disc to stay nice and healthy, and it gets water, oxygen, nutrients that are within the actual spinal bones themselves, the vertebrae, to get in and out of there, and it flushes out inflammation and waste products. But the problem is, with a lot of patients that they come to see me, is they having these disc compression and bulges and herniations, and they're not having the disc, are not pumping, they're not moving it the way that they should. So really the whole goal with decompression therapy is to allow the disc to pump once again and get that water, oxygen, nutrients, and for patients that are candidates and have the disc compressed and push upon that nerve root, right, we want to be able to pull the disc off of the nerve root, so of course they're starting to feel better and they're not having to go through surgery, injections, or endless pain medications. Now, the body doesn't like to get compressed. It doesn't like irritated tissues. And so if we're constantly irritating the tissues and we're doing too much therapy, then the decompression isn't going to work, right? Decompression is not magic, it's a tool, and we have to utilize it properly, okay? And if we don't, and we over pull or under pull, it's not going to work very well, right? In order for us to decompress a disc, we have to set the weight for enough weight to decompress and pull the pressure off of the disc so we can elicit a change. But if we don't pull with too much, we'll have no change at all, or we don't pull with enough, I should say. So there's a fine balance, and it's actually dynamic. It's not static. It's going to change from patient to patient and visit to visit and day to day. So we have to be thoughtful and mindful of many, many different factors when we're dealing with decompression, right? Not all decompression is the same. The equipment really does matter. Now, are a couple, I would say, 3, maybe 4-ish tables that work really well. We happen to use what's called the RX9000 spinal decompression. In my opinion, those are one of the best tables. There's some other tables that work very, very well. The reality is it's just a tool, and if we don't utilize the tool properly, then we're going to have limited responses. Now, we have to really look at each patient, right? What kind of condition did they come in? How long have they had the pain for? Where is it? What kind of shape are they in? Do they have more adipose or fat tissue? Do they have more muscle tissue? That's going to be very, very telling for what type of therapy we're going to treat, how often, the strength. We have to also know what's their tolerance, right? What does the x-rays show? If they have an MRI, what does the MRI show? The physical exam is extremely important, and if we don't do a proper physical examination, we're going to have subpar results, if any. So it's very important that we actually do that. We also need to make sure that we have proper stability in the spine. In other words, that spine can handle that. Typically in a spine, when you bend it forward and backwards, the bones should be tipping, not slipping or sliding. If they slip or slide, this is called spinal instability. And I tell patients, if they have spinal instability, at least in my office, if it's fairly clinically significant, we are not going to decompress that segment because number one, it's probably not going to help them. Number two, it may create more instability. And number three, it's really kind of a waste of their time and their financial resources. So we will potentially treat those patients in different ways, or in some cases we need to refer them out. In those cases, if it's severe instability, they may need to go through a spinal fusion surgery. And so we don't claim that we can help everybody. If we can, if we cannot, then we're going to send them to the correct treatment protocols, and that may not be ours whatsoever. So now, when we're doing decompression, even little small changes can dramatically, change how somebody responds. So we need to make sure if the angle, right, is where we're originally pulling with someone, and let's say it's flat, for example, well, maybe they're not responding, and maybe re-looking at their x-rays, or maybe they're starting to change a little bit the way their body is moving, and sometimes we just change that maybe 5 or 10 degrees. That can make all the difference in the world for somebody. Or if we open the table versus keep it closed, or if we open it maybe 25% versus 50 or 100%. So it's very, very important that we understand the intricacies of the discs and how it works. Do they have an annular tear? Is there a fissure? That's going to create a lot of sensitivity within that disc, and we have to be very thoughtful and mindful of that. If we go in there all hot and heavy and we pull real strong with somebody and we open up the table, we can quickly aggravate that problem, and that disc can get really kind of pissed off at us, and we may need to calm it down for a week or two before we get them just back to baseline. So you can start to hopefully understand that there's a lot that goes into this type of situation. We need to make sure that our clinical judgment is constantly working. And so this is why we don't have therapists in the office make clinical decisions, because they're not trained to do so. They're trained to follow out, and they're very good at helping people get on and off the therapies, but they're not trained to set parameters, the weights and the angles and the pulls, and dictate how long they're going to be on there. That's for somebody who has the experience. And make sure that if you're seeing somebody, that's not the case. You should be having the doctor should be, very often checking in with you if you're undergoing decompression therapy, or any therapy for that matter, versus only having nurses or spinal techs or therapists or assistants only checking in with you, right? Treatment should be dynamic. It's not static. It's going to change, right? We've had patients come in from other clinics who have actually undergone decompression therapy, didn't get better, and their protocols were just not very thorough. They weren't very good, to be frank, and they weren't really changing. So let's say the patient's going through 3 or 4 weeks of treatment, and they're in there 3 or 4 weeks, and there's no change whatsoever, and nothing's really changing on the treatments. We really need to make sure we're doing proper reevaluations, reassessments, we're changing things, we're adding things, and we're making sure that the patient is responding, right? We don't start telling them they're going to need 4 or 5 months of treatment. We don't know that. They may only need a month of treatment, right? Or if they're not responding for some reason, we're going to need to have a plan. How are we going to change their treatment? What are we going to add? What are we going to take away? And how thorough are we being with what they're doing at home, right? They're only in the office for a very small, minute portion of their week. And so what they're doing outside of here dramatically can change the outcome. So that's something that we go over very specifically in the office with every patient. Now, the body types are all a little bit different, right? There's a reason why, if you look on any podium for the Olympics, the shot putters all look the same. The javelin throwers look the same as each other, I'm talking about. In other words, a shot putter probably doesn't look very similar to someone who throws the javelin, or the 100-meter sprinter is going to look very different from the marathon runner. And there's reasons for this. So we have to be thoughtful and mindful of this, right? We can't just treat everybody the same. Let's say somebody comes in and they're 200 pounds and they're maybe 5'6", and someone comes in and they're 6'6" and they're 200 pounds. Well, we can't treat the 200 pounds only. We have to look at their frame, right? So there's very big differences in the discs, the anatomy, the physiology of how that works, and the loads that they can handle. If someone's a little bit more thin and wiry, right, they may not be able to handle compressive forces so well. So kind of think of like a willow branch. It's real bendable. You can twist it back and forth, up and down, and it may not even break. It just kind of moves around. But you could take a stick, right, like a harder stick, piece of wood, and you could start to put force into that, and it may snap fairly quickly, but that stick can hold a lot more compressive force, where the willow branch, as soon as you try to compress it, what does it do? It just flops on over. So how does this work in practicality on a day in and day out basis? Well, I can tell you the patients that weigh maybe 200 pounds and 6'6", I'm going to pull a heck of a lot lighter than the person who is 5'6" or 5'8" and weighs 200 pounds. They probably have a lot thicker trunk, and they need to have more decompressive forces because they can handle a lot of force. So this is the kind of art and the intricacies of what needs to happen to get those positive responses. And if people are getting treated where they just step on a scale and say, hey, this person weighs 200 pounds, and they have a protocol that they've been taught, hey, pull at this person half their body weight minus 20 pounds, and then they're going to add 10 pounds every visit, open the table up for every patient, you can see how this is probably not going to work well for everybody. So it's not a one size fits all. We really need to make sure that we're doing a good job of specializing and being very unique for each one of the patients, okay? Who is a good candidate? Not everyone is candidate for decompression. So in our office, we really look at some specific things. Number one, their history, right? Is their history very classic and typical of a disc problem, or do they have some weird things that they're telling me that I got to start kind of getting a little suspicious about? For example, are they having back pain, but it's more kind of on the side and kind of wrapping around? Is it more recent? Have they been having nausea, right? That could be something going to go with a kidney or some kind of other internal organ, right? It could not be their back pain at all, their disc at all. It could be something completely different. So we really need to make sure we're paying attention and we're not just checking out and just trying to process this patient, and make sure that we're being very unique for each person and specific. We have some patients that have come in from other offices, and it's the same, everyone's got a disc problem, and it's just not the case, right? It doesn't work that way. So we have to be mindful and thoughtful of this, and not make sure that we're just forcing people into treatments for our own benefit and or the clinic's benefit, right? We really have to look at the patient. What's their pain pattern, right? What was their mechanism of injury? This is a very, 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 I can't stress how important this is, right? Are they 32 years old and they've never had back pain, and they're having horrible back pain, and a week ago they did a really heavy deadlift or heavy back squat, right? That's going to tell me a lot of information. Are they 48 and they had that happen, the same case history happen at 32 and then 38, and now they're 48 and they started to get back into shape, and the same thing happened? Did they have an injury playing a specific sport? Did they have no injury at all, and they are a computer operator and they work basically at a desk and they sit, and they've been doing that? We have an accountant, she's been doing that for 30 something years, and she doesn't play any sports. So you understand that we have to make sure that we determine who is going to get treatment, and how are they going to get that treatment, how often, right? We can't treat the 90-year-old patient the same as the 29-year-old patient. Typically, there has to be some thought and process into that. So we need to make sure we're listening, and we're really doing a thorough examination and a history. Now, the physical examination portion, we have to see what their body can tolerate and not tolerate. Some people cannot tolerate, for example, at all, bend into a forward position, and other people can tolerate it all day long. Some people can bend backwards and they feel significantly better, and some people are stuck in a forward position. Well, that's going to tell us some information. Are we possibly dealing with spinal stenosis? Is there possibly what's called a spondylolisthesis, right? A bone that's slid a little bit forward. So we have to be mindful, again, and thoughtful of all of these things constantly. Otherwise, we're going to have subpar outcomes because maybe that person wasn't even a candidate in the very first place for decompression. We have to make sure that they are stable. So nobody gets on decompression, at least in my office, unless they've passed through, they have stability within either if it's their neck we're treating or the lower back, we do what's called flexion and extension x-rays, where we talk about, again, when they bend forward, those bones should be tipping and not slipping or sliding. Now, if they slip or slide a couple of millimeters and everything else is okay, many times we can help with that. If they're slipping and slides, 7, 8, 9, 10 millimeters from a neutral standing straight and they bend forward and it does that, that's a no-go. So that's another indication, right? Our job is to determine, is the spine stable enough to decompress it or not? Last month we had someone come in, she has severe osteoporosis. Her T-score was minus 3.3 with severe risk of fracture in her spine. We are not decompressing that person. She was told by somebody who does decompression a little bit north of our office here in Escondido area that she needs, I think they said 30 treatments and it's $10,000, and she almost did it because she's desperate. She's in horrible pain. That being said, we found her a physical therapist that we think is going to be really good for her, and hey, that's the way you got to do it. You got to think about things, okay? Now, MRIs. This is my almost 22nd year practicing. My first 5 years doing decompression, I required every single patient to have an MRI. But then I started coming across studies. There's false positive, false negative MRIs all the time. An MRI basically is a roadmap of where your spine has been. They're useful, but they're not always necessary. If we have a good working diagnosis, good history, good physical exam, we have flexion extension x-rays, then, if we don't see any red flags, or if we're unsure, of course, we're going to refer it for an MRI, absolutely. But a lot of patients do not need MRIs. Now, in my office, let's say we're treating them and after a couple, 2 or 3 weeks, they're not responding, then typically I'm going to tell that patient, and I tell them at the beginning, listen, if we're not responding after a couple, 2 or 3 weeks, let's get an MRI. Doesn't mean we can't help you, but I need to get some more information on there, right? Is there more than potentially one disc involved? What's the size of it? Is it looking more of a herniation? Is it protruded, extruded, sequestered? Is there a fissure, a tear, right? These type of things can help to determine and change settings dependent. So we have to be thoughtful, again, and mindful, and it's not, again, a one size fits all. This is where the clinical skill makes a big difference. MRIs, basically, they're roadmaps of structural, it's like a scar, right? Like 10 years ago, half my nose was hanging off from playing hockey. It hurt really bad then. It doesn't hurt anymore. It's this big and looks ugly, but it doesn't actually hurt anymore. So we're gonna treat people, not MRIs, right? Sometimes we have patients go, oh, can you look at my MRI? I want to send my MRI, see if I'm a candidate. And I go, well, I don't know if you're a candidate or not. It depends, right? There's many more factors. Someone brings in an MRI. We had a patient had this happen last week. And I went in and they right away, did you look at my MRI? And I said, no, not yet. And they, how? They had this look of confusion. Because I don't want the MRI to influence what I'm going to see on your physical examination, right? We want to do a physical examination and hear your history. And then I can start formulating in my mind what I think the MRI may look like. But again, I don't want to go in there with a biased, this is what's going on after looking at the MRI. So that's the way that I do it. It works very well for me. That doesn't mean that every single doctor has to do that. But I hope you're getting the point that there has to be ongoing clinical thought, and there has to be some reasoning and some options for choice making, and not just jam everybody into same protocols, same treatments. Okay. Decompression, it can't be passive only. In other words, so decompression therapy, right? It's fantastic. It's great. It works great. I use it on my own back, my own neck. There's no way at 51 years old I'm still surfing and playing golf and playing hockey and lifting weight and doing all the things that I do without decompression. It's just not going to happen. Okay, so it's great. However, it's passive, right? You come in, you land a piece of equipment, feels great, works wonders, but if we don't involve the patient into active therapy as well and make sure that we are either giving them, what do they need? So this is where, physically examining them, watching how they move and taking them through some stability testing makes sense. Some people need a whole lot of stability in their spine. Others have that dialed in right away. Some people are really stiff and tight in their hips, and so we need to get some mobility working in their hips. Other people need posture, and some people need a combination of all of these things. So the active therapy is extremely important, that we not only realize that people need active therapy, but it's specific for each patient. In other words, people don't get the same exact exercises or stretches or what have you. It is going to be specific to what we see on physical evaluation, physical examination, and then what is their day like? Are they a construction worker that has to lift really heavy loads and have to bend a whole lot? Are they computer programmer person that's sitting down at the computer? Do they have a standing work desk? How old are they? What are their outside influences? Do they have small children they have to bend over and care for? Do they have an elderly parent they have to care for? So there's a lot of factors that we have to think about with this. What kind of sports or activities are they doing? And realistically, given their age, the stress, and what's happened with them, can they keep doing those, right? So, like, for example, we had a patient that came in. He's John's, how old is he? He's upper 60s. Great guy, he's doing fantastic, but kept having these little flare-ups. He'd get better and then have this flare-up. And so I kind of asked him, John, what is happening? What's going on? And he's like, well, I picked up pickleball again. I'm playing pickleball. And so he's playing pickleball like 3 days per week, 4 days per week. And so pickleball, you're having to bend a whole lot. And he, in his particular case, this is a big debate, the flexion intolerance, and people saying you should never flex your spine. I don't think that's the case. I think you can flex your spine as long as it's done safe in an appropriate manner. But it also depends on, is there tolerance to that? I don't have a lot of tolerance for bending forward a whole lot, so I don't do that a whole lot. Anyways, I'm getting sidetracked. The point is that John is playing pickleball 4 days per week, and he's aggravating his back all the time. So I asked John, how important is it that you play pickleball 4 days a week? He said, I don't, it's just exercise. I go, okay, what would happen if you played like 1 or 2 days a week? He said, that would be great, but what do I do the other 2 or 3 days? I said, well, what if you take a nice long walk or you go for a hike? Does walking or hiking hurt your back at all? He goes, no, never. And I said, perfect. So these are the thoughts and the mindsets, right? Now, if that person says, listen, I have to play pickleball, it's like my life, well, then we have to have a conversation about that, right? The exposure and the prolonged compressive forces may not be the best for his spine, so he's going to have to either live with the fact that when he plays pickleball, it irritates his back, or maybe come to some kind of, playing twice a week versus 4 days a week. So again, but these are conversations we have to have with our patients, in my opinion, and be mindful and thoughtful. And hopefully, again, you're seeing that, there's so much to this. It's not just does decompression work. It can work with the right combination, the right education, the right passive therapy, along with active therapy, and the right things to do at home and thoughts. So you can't just say it's a one size fits all. It works, it doesn't work. It can work for a lot of people if they have proper guidance, a proper plan. There's reassessments, we have proper angles, we have proper not only passive therapy with the decompression, we have proper active therapy, and they have proper mechanics of how they move their body, right? Something as simple as, listen, we have patients that are flexion intolerant, meaning they can barely bend over, right? They can barely get into a position where they can bend. And every time they sit, what do they, so their first movement? They bend forward. So if we can train them to sit and stand straighter in their spine, and they're not flexing forward, it's going to make a big difference. If we don't train them on that, and we don't discuss that at all with them, we're doing a huge disservice. So all that to say, spinal decompression, it's incredibly valuable tool. It is only a tool. We have to use right decision making, right treatment plans. It's not magic. It needs to be done in an appropriate manner. And so there's several different factors. So hopefully this has been helpful for you. If you're suffering from some neck pain or back pain, sciatica or degenerative disc disease, these kind of things, and you want some help, make sure you see somebody that knows what they're doing, right? Don't see that person that's really knowledgeable. They've had experience in treating these type of situations, and there's mind and there's thoughts that go into this, okay? And if you want to see if you're a candidate for treatment in our office, just reach out to us. I'm more than happy to see if I can help you, and you can give us a call, and if you have any questions, let me know, and hopefully this is helpful. Have a great weekend.